and thanks for the organisers for inviting me today. So I've been asked to talk about, oops, gosh, it was all working wonderfully well a minute ago, and now it's all stopped. Sorry. I'm going to stop sharing and try again. Sorry about that. I don't know what's happened here. There we go. Sorry about that. So I am going to give a brief overview of the infected blood inquiry, looking at the events of transmissions of hepatitis C, HIV and other infections during the 70s and 80s from blood transfusions and blood products, specifically around the recommendations, but the other broader issues as well that became part of this. So, as many of you are aware, there have been previous inquiries, but these only occurred after many years of lobbying by those infected and affected. The initial inquiry was the Archer inquiry, which wasn't a statutory inquiry, in 2007. And then in Scotland, there was a Penrose inquiry, which reported in 2015. However, that made very few recommendations, the main one being about following up patients and making sure that they had been tested for hepatitis C. So in 2017, the government announced that they were going to launch this inquiry, which would be led by Su Brailsford and would be a statutory inquiry. So this commenced in September 2018. I think at the time, it thought that it might take around 4 years. It did take somewhat longer than that. So the scope of the inquiry was very wide. It was to cover the whole of the UK. In terms of those people affected, they were considering 3,000 deaths and probably up to around 30,000 people who had been infected by hepatitis C and other infections. And also, although the time frame was concentrated mainly in the 70s and 80s, Sir Brian did really look at evidence going back earlier this, even to the start of the blood services. From the outset, there was a commitment to the affected and infected, and as part of this, there was a list of issues, which are basically a living document, and this was added to as the inquiry went on. So as I mentioned, really, the inquiry was about putting the people affected and infected really at the centre. From the outset, it was really about being open and transparent and being listening and showing respect to all of those really who were given evidence. So the inquiry was published on the 20th of May, and here are the links to the report themselves, which was in 7 volumes, many, many pages, and also on the website that there is the actual day of publication when there was a reflection ceremony, which was very moving. And for those who haven't seen that, I would recommend that you do look at that. So the recommendations were 12 recommendations, but within these, there were several other sub-recommendations. So really, it's probably closer to 50 plus recommendations. And the ones here in bold are the ones that I'm going to concentrate on today, and which are probably most applicable to the blood services. So really, the first one is around education and learning from the inquiry. So Brian's very keen that all of the information that has been collected and is on the website remains on there for the future, that it is curated, and that really NHS England and the GMC should be looking at using information from the inquiry and testimonials as part of training. In the report, it specifically talks about medical people and doctors, but I really think this applies to everybody who are involved in transfusion. So it was really an important point that what happened should be remembered and should really be incorporated into longer term training. So recommendation 4 was about preventing future harm and achieving a safety culture. Some of these things are things that have come up in previous inquiries, particularly around regulation and safety management. But the inquiry had some specific things to note around duty of candour and patient records. So in terms of duty of candour, it was acknowledged that there has been a lot of work from the clinical point of view, but one of the recommendations was really that this is extended much more into people in leadership positions, and that really there should be an obligation on people that if something has gone wrong, then that really should be declared and something should be done about it. Really following on from the recommendations about lack of openness and really preventing this culture of defensiveness, not only talking about the NHS, but also more widely in the civil service and elsewhere. There were some specific recommendations about digitisation and an audit of patient records to be carried out before the end of 2027. And also there were comments about the ability of patients to be able to access their records and also to change records if there were inaccuracies in those. And as well, there were a lot of comments throughout the report about data, but specifically as all of the UK blood services are collecting data, making sure that is used for trending across the whole of the UK rather than looking at data just in specific regions or areas. So recommendation 7, hopefully this is the one that most people will be aware of. And as we heard yesterday, there has been quite a lot of work in some of these areas, but the recommendations will help, we hope, as a lever to push some of these forward. So many of these recommendations we'll hear about later today, particularly as some of them are already in the Transfusion 2024 work that NHSBT were doing. So yesterday we heard a lot about tranexamic acid and also other alternatives to transfusion. The recommendation in the report about benchmarking use of tranexamic acid and really auditing that closely. There were recommendations to continue and monitor progress against Transfusion 2024 and the Scotland 5-year plan. Again, an emphasis on training in transfusion and also about staffing in laboratories. And I think in a moment we're going to hear about SHOT, but also how SHOT recommendations should be implemented. Although there wasn't a recommendation to make this statutory, there was really a push how this should be monitored more carefully. And also, again, with digitisation, establishing the outcome of every transfusion. So I think, and also in terms of monitoring the outcomes of transfusion, really using that to improve practice and to be able to use that for other purposes in the future. So recommendation 8 was around finding the undiagnosed, and most of this will fall with NHS England and with the UK Health Security Agency, particularly around testing people as they apply to join GPs, but also I think as a small part, there is the role that the blood services play in look-back investigations of those donors who seroconvert, and also we do get a number of potential transfusion transmitted infections to investigate as part of this. And then recommendation 10 was around giving patients a voice. So certainly in terms of including patients in clinical audit, but there are also comments about specific charities should receive money so that they can continue their patient advocacy. And also within this recommendation, there was also the need for a more holistic approach to those people with thalassemia and sickle cell disease, including some psychological support. And one of the other comments was about really using a yellow card system in a similar way that it's used for pharmaceuticals to allow people who have had adverse impact of blood transfusion to be able to report those. I think the part about giving patients a voice probably goes above and beyond that. The report noted that people had not necessarily been consented in the past, and we know from audits that consent is not as good as it might be, but also within the report, people had said that they had been given false reassurance. So really, there is that importance of shared decision making that we've already heard about this morning, and really the issue of people having sufficient information to be able to make an informed decision and properly give informed consent. The inquiry also talks about there being a poor understanding of risk and maybe not always having the right people involved in talking about risk. But I think all of these considerations here also impact on other work around research and other policy changes that we make. So I think it's really important that we do take this on board going forward. So some of the there's a number of wider issues that the report talks about, and it also makes the point that previous inquiries have brought these up again and again, and most recently in the COVID inquiry. So things around corporate memory, failure to learn from past errors. I think specifically with the infected blood inquiry, many of these took place at the time when blood services were much more fragmented and they didn't have a national approach they have now. But there was comments about having a number of committees who really didn't seem to be able to make a decision because they really weren't very joined up. But then on the flip side, also the report talks about groupthink and having kind of the same people making decisions over and over again, and really being quite difficult to challenge. So I think really there is something as well, both in this report and previous reports, about how ministers are informed about risks and whether they always fully understand quite what's going on in their brief. But I suppose really the main thing from the whole of the inquiry is failure to learn from previous errors and how we overcome this in the future. So given that really the infected blood inquiry, the main focus was about infections, really think it's important to make some comments on really what went wrong at the time. And at this point, I'd like to reassure people that things have obviously changed in terms of safety measures and tests and really how we talk to donors now. But some of the issues really were around the slowness, how long it took to make decisions. So once the decision had been made, also the time to actually implement things. This was particularly true in terms of some of the donor selection information at the time and the implementation of hepatitis C testing, but also importantly the hepatitis C look back, which didn't take place until 4 years after testing had been introduced, which meant there were missed opportunities in following up patients. And some of the issues around introducing testing was really because people were looking for that perfect test rather than going with something that was good enough to meet the public health need. The report also comments on how there was concern about adverse publicity, which may have led to delays with the AIDS leaflet. But again, there's also this issue about understanding risk and being able to put that into context. So these days, there have been a number of changes in terms of surveillance for infections, not least, of course, the SHOT. Also, we now have national surveillance systems for infections, so that there is an Epidemiology Unit which collects data across the UK and monitors across the UK. There's also, in terms of horizon scanning, we now have procedures in place under the auspice of JPAC, Joint Professional Advisory Committee, that is really monitoring for new and emerging infections. And also we are still quite reliant on people, they reporting suspected transfusion transmitted infections to us that we can follow up and investigate. So I think really it is about making everybody be aware of their place in the system. And of course, part of this in England most recently is the introduction of PSERV, where events, including transfusion transmission events, will be followed up, and the reasons for these try to be ascertained and then fed back as learning. But although we have all these surveillance systems in place, it's very important that we don't get complacent, and particularly from a public health point of view, generally when you don't hear about anything going on, that means that things are going well, but it doesn't mean that we should discontinue surveillance. Or I think in the report it does acknowledge that probably during the 70s and 80s there wasn't enough investment in public health services, so that's also quite important on the broader systems of surveillance as well. So that's kind of what the report said. In terms of implementation, there's lots of work going on. The individual UK blood services have their individual plans, and for NHS Blood and Transplant, information as to what we're doing is on our website. UK blood services is working together as part of the UK Forum. SABTO has are in the process of reviewing their role and whether there's anything additional that they need to do post the inquiry. And also there are a number of NHS England and DH committees ongoing at the moment, but all of these will report up to the Cabinet Office. And certainly Sir Brian did say quite clearly that he expected that action would be taken within 12 months of the report. We are now 6 months post the report, and this week Parliament did actually discuss the infected blood inquiry and where we are with compensation. So the compensation framework is being put in place. That still isn't quite there yet, and there is still quite a lot of work to be done. But I think there is certainly the expectation from Sir Brian that he will be given a report at the end of those 12 months, and where recommendations haven't been introduced, he's expecting to know why that is the case. So I think that brings me to a close. I just have some acknowledgements, obviously, for all of those people who are infected and affected who gave evidence to the inquiry, and colleagues within NHSBT and the wider legal team. Thank you so much.
Sue, that was a terrific